Okay, we're live on here. Give me 1 second. I'm just going to get us live on Instagram as well. Okay. Hello. On here. Give me 1 second. I'm just going to get us live on Instagram as well. This is not good. Hold on 1 second. There we go. Okay, we're good to go.
Yeah, awesome.
So, hi guys, how are you? This is Dr.
Hello.
Dana Mincer
Dana.
with Love Health Direct Primary Care. This is my podcast called The Unfiltered Doctor. And if you've listened to this podcast before, you know we talk a lot about breaking down healthcare silos, and today's guests are doing exactly that. I'm joined by two forward-thinking physicians who have come together to build a truly integrated model for musculoskeletal and pain care. Dr. Eric Addo is a dual board-certified diagnostic and interventional radiologist. He is the visionary behind Wisteria Imaging, a state-of-the-art center that brings cutting-edge, community-focused imaging to the greater Philadelphia area. Trained at Columbia University Medical Center and published in Radiology, Dr. Addo has built an impressive academic career, but his real mission is prevention, helping patients catch diseases and pathology before it's too late. Joining him is Dr. Christian Acharte, a board-certified physiatrist specializing in pain management. Dr. Acharte completed his undergraduate and medical degrees at the University of Connecticut, followed by residency at the University of Pennsylvania, and fellowship training in interventional pain medicine at the Pennsylvania Pain and Spine Institute. He now leads Wisteria Pain and Spine, where he delivers truly patient-centered care for chronic pain and spine conditions. Together, they founded Wisteria Health, an innovative partnership between Wisteria Imaging and Wisteria Pain and Spine, built to bring integrated, collaborative care to a space that's often fragmented and frustrating for patients. So Dr. Addo and Dr. Acharte, welcome to the Unfiltered Doctor.
Thank you very much, Dana.
Hi. So I'm so glad that I met you guys. You guys opened up this beautiful imaging center right there in Wyncote, sort of, we call it like bordering Wyncote, Cheltenham area. For those of you who know the area, it's right by the Home Depot, which is great. I just wanted to sort of open up the conversation today to have people understand a little bit more about what you do in the realm of holistic services, basically. So I loved our initial conversation because I felt like we had a very similar view of the medical world and also like the insurance-based world and how the traditional system is often failing patients and providers alike. So who wants to start? I have questions for both of you. I have questions for, but maybe, okay, why don't we do this? Dr. Addo, why don't we start with you? Tell us about your background and, like what drew you to radiology in particular?
Yeah, that's a great question. Honestly, when I started med school, I thought radiology was boring. Honestly, I wasn't really introduced to radiology until my third year in med school. I think as most med students and most people, they think radiology, you're sitting in a dark room. You're not really impacting anyone's life. You're just there drinking coffee, having lunch. But radiology is actually, it's a great field. At the end of the day, you are the one making the diagnosis. And that's what I found exciting about it. Everything comes down to what's going on, how do we treat it, how do we get the patient out of the emergency room, out of the inpatient setting, and just get them home with their families. So that was the exciting part about radiology. And that, honestly, I felt like that trumped any other specialty for me personally. And then I did interventional because I know I can treat and diagnose at the same time. So that's kind of a quick overview of what brought me here in the first place.
Awesome. Okay. And Dr. Acharte, what about you? What is it that you're doing things a little bit differently as well? And you're doing the interventional side of physiatry. And I don't know I'm sure other doctors understand this concept, but tell us more about like why you're doing what you're doing and what your goals are with it.
Sure. So I guess I ended up in physical medicine and rehab, and then eventually in pain, kind of like Eric, because of something that happened during medical school. Actually, at the very beginning of medical school, my family had a hard time. My father ended up almost overnight becoming an incomplete quadriplegic. And after he was medically stable, I noted that a lot of hardship came on my family, not because of any medical complications that were kind of settled shortly thereafter, but rather pain complications. In not so many words, it almost broke up my family, and it wasn't until my father got at least moderately good pain management 3 years into his injury that my family started the process of healing, if you will. It kind of formed a specific viewpoint that I had for medicine thereafter, and it kind of inculcated me towards PM&R and ultimately pain management. So that's how I got here. I think that perspective, that origin story, if you will, kind of gives me a very interesting look at my current patient population, which is I treat both acute and chronic pain. And it gives me a perspective of saying, yes, these people undergo very difficult treatment from a medical standpoint because of limited options, whether it be medication, injections, and what happens once they fail. But also, like going back to the human aspect of medicine, these people are hurting. They need more than just an overly complicated jargon statement. They need a hand and a shoulder to trust and lay upon while being guided through this medical journey, this process of healing.
And how did you guys, that's very powerful what you're saying. First let me say that I think that oftentimes the most difficult things in life, at least for me, that I've been through, the ones that I thought were going to break me, have been the best learning process. And they really have helped to guide me and my light in terms of where I want to take my patient care and who I want to be in the world as well, right? Like it's a double-edged sword. This horrible things happen, and then when we move through them, it really like opens up this whole other area of understanding. And I think that with that understanding, it helps to relate to all people in general, because I felt it, I've touched it, you know? So how did you guys get together? Like, what was the thought process behind, we're going to open up this sort of these sister companies, right? Is that what we're calling them? And form Wisteria Health.
So I guess the backstory is Christian and I went to med school together. We're roommates, so we're good friends for years. Probably 5 to 6 years into our career, we went our separate ways. He was in pain, I was in imaging, and we kind of came back together and we're like, hey, in our respective fields, we see that there's kind of a disconnect between patients and the care they're given. At the end of the day, patients just want providers that care, providers that will do the right thing. And we're seeing too much as providers doing things based on what's the imaging study that's going to give the most money, what's the procedure that's going to be the easiest to do, but not patient-centered. And I think that was the thing that Christian and I came together and we're like, hey, let's create a practice that's focused on the patient and has the patient at heart and in mind. And we know the biggest thing is prevention. So we both kind of jumped on that bandwagon. We know that at the end of the day, if a patient doesn't have to come to the hospital day one, then their lives and their outcomes are better. So why not catch it early? So that's one reason why we came together and we decided that this is awesome. We can focus on preventing patients from getting to that stage where they're in the hospital, in the ICU, for pain or for cancer or anything in between. So that's kind of the backstory of how it all started.
Got it.
And I'll jump in and say just one more thing. Like, I think that was beautifully expressed, Eric, but also like, I think coming together, especially as physicians, I think we all work very much autonomously, but coming together in a business venture like Eric and I did with a common goal can be kind of daunting, especially at essentially something that's tied to the greater financial system like American healthcare. And to do that, you really need to go into it with someone that you trust. And having known Eric for more than 10 years, having lived with him for more than a few years, and like honestly calling him one of my best friends, it was a no-brainer. And anyone else that wants to go into this, I'd say really there has to be a lot of trust within the space, and that your partner's going to be doing the right thing.
Yep, I agree
Yeah,
100%.
100%. Yeah. I think it's interesting what you were saying about like sometimes maybe tests being ordered for the wrong reasons, or I think there's like a general distrust that has started to happen over many years where we've definitely already stepped out of the paternalistic system of medicine and how it used to be. um, I was one of those patients that was diagnosed with 2 autoimmune conditions in my first year of residency. And I felt very gaslit by this like paternalistic system and I still experience that now when I'm fighting for my patients, right? When I'm calling up specialists and I'm like, no, this is what's happening. Like, you need to take this person seriously, you know?
Mhm.
Um, and also just like the concept of, hey, acknowledging that there are constantly things that we might not know, right? That getting the ego out of the way to say, historically in medicine, there have been many things that we've implemented as standard of care and then have later pulled back and said, oh, we were wrong about this. But it usually takes, from what I see, about 20 years for that to happen, right? In terms of the opiate epidemic and everything. So I don't know if you guys feel comfortable sort of discussing a little bit further what you're doing differently, I guess, for the sake of just, political correctness. We don't necessarily need to put anybody else down, but like, what were your frustrations specifically on the radiology side, so that people understand, and then also on the pain management side, and how are you changing that paradigm?
Let's start off. So, being in the hospital, the truth is, seeing ICU patients, that's where the highest cost to the healthcare system is. It's in the ICU. Patients are sitting there for days, and it's heavy on the system financially. And I would say it's all preventable. Working in the hospital for these 6 years, I see it firsthand every day. And that's kind of where I see that there's a level of disconnect in improving healthcare outcomes and physicians working with patients. So I feel like patients need to understand that it's early, like it's deciding between a hamburger or a salad. That's actually what makes the difference. And in the imaging side, for us, technology has advanced significantly over time, and we have so many options to prevent this. So we have lung cancer screening that we do. We have coronary CTAs where we can catch plaque beforehand. We have mammography to catch cancer early. I think now with the technology advancements, there's just no excuse um, to have patients just keep getting sicker and end up in the ICU. And I think that's what I think medicine should move towards. And I just see a lot of radiology center just saying, hey, we'll do this study, we'll do this study, just because it brings in money. I want our center, and that big thing in our center is that we're going to do what's right. I mean, money's important, but at the end of the day, what's right for the patient is the most important thing. Like, do they need this scan? Do they need this radiation? And from there, you can make your decisions. And I think prevention and decreasing radiation are the priorities at Wisteria.
Okay. So another follow-up question to that then, and this is more specific. Coronary calcium score versus CCTA,
Mhm.
which is, for people that don't know, it's an angiogram study, and you can explain that if you want, paired with AI analysis. I know we've talked about this a lot.
Yeah.
I am at a point where I'm ready to, and maybe I'm wrong, and you can correct me. I am at a point where I'm ready to just like completely dismiss these coronary calcium scores because we have this
Yeah.
other incredible imaging. Um, if you want to just maybe explain the alternative imaging that I'm talking about and how it works in basic level, and then just tell your opinion on, what we should be doing.
Yeah. So I actually see it from the radiology side, and my wife's a cardiologist, so I hear her stories from the cardiology side. Calcium score is a good test, but it's not the end all be all. The issue, what I mean by that is calcium, you could have calcium in your coronary arteries, and obviously you have coronary artery disease. but you could have a negative calcium score and still have non-calcific plaque in your coronary arteries and have really bad disease. So that's what a lot of people don't understand. They're like, hey, I have a negative calcium score. I'm healthy. Everything's great. It seems that way, but you could have non-calcific plaque and you could have a heart attack tomorrow. So I think catching it before it happens, again, this is the biggest thing. I see it with a lot of cardiology patients. Coronary CTA is the future. So that's what prevents you from having to go get a cardiac catheterization, which in simple terms means that they're going to stick a needle in an artery, go up into your heart, and look at your vessels firsthand.
And
They're going to
correct
use
me if I'm
sedation.
wrong, by the way,
Mhm.
but my understanding was that 40% of people, or around there, maybe 30 to 40% actually get a cardiac catheterization. They don't
Exactly.
have any findings. So
Exactly.
you're doing this pretty invasive procedure by snaking this tool up a major artery to just find out that they don't have findings.
Exactly.
Right.
So that's the thing. You're going through all of this just to find out versus doing a simple CT scan, coronary CT. You can look at the arteries. You can look, there's at this point, AI technology is in everything and it's in coronary CTA. So you can see what type of plaque is it calcific, is it non-calcific, is there areas that are narrow, stenosis, is there flow that's not normal, so fractional flow reserve. So basically flow that's abnormal in different areas. You can see all of that from a coronary CTA. And this is all something you can do without having a needle put into your artery and going up into your vessels. And let's say that's positive. Okay, you need to do the cap. You need to go ahead and get a stent. So that's completely fine. But if it's negative, obviously you just prevented a large procedure that has its own risk by doing a simple test. So I think this is the future and it's definitely important to prevent. There's two pathways, and if you take coronary CTA, you catch it early, then patients are doing great. If you avoid screening and you go the other pathway, you end up with plaque, you end up with disease, you end up with cabbages, you can have stents, and your trajectory in life has changed completely. Your next step is a transplant. So you have to decide on what trajectories you want in life. And catching it early is the biggest thing because people don't understand. Even if you get a transplant, they're only good for 15 to 20 years. So let's say you get a transplant at 40, you're good till 60, and then the transplant will fail. So some transplants last longer, some transplants last shorter time, but that's the average. So you have to think about it like it's a lifelong trajectory of disease. So
Yeah, and
it's
I
kind
think
of
if I had it my way, like I practice, I don't separate out lifestyle medicine from primary care. That was the whole point of opening my practice. I was like,
yeah,
this doesn't make any sense to me. It makes
yeah.
sense in the traditional insurance system where you don't have time, right? And they don't teach lifestyle medicine during med school. So then it makes sense in that like some people who don't have a background in that need to go out and get more training. So so from my perspective as a lifestyle primary care doctor, I feel like I want like most of my patients just to get this at age 45 or 50 and have it done once every 8 to 10 years. Because if we can catch, like right now, if you wait until you have symptoms to do something about it, it's too late at that point. But
Way
if we
too
can
late.
catch these things early and we can say, hey, listen, you have a little bit of decreased flow in your coronary artery. Come, let's sit down and talk. Let's talk about your full nutrition intake. You know, it might be worth considering going vegan. It might be worth, you know, some interventions. I also sort of see it as opening up a space because so many more patients are coming to me at least and saying, do I need to be on the statin? I really don't know. I don't know. And we know that there are some people that just live at higher cholesterol levels. Like that's just where they live and they might be fine there. So I think this type of imaging, which, you know, we can also get it paired with the AI. Well, it is paired with AI analysis, right?
Yep.
Is awesome. And you don't need your insurance to cover it. That's the thing. Like in my mind, you know, for, you know, under $1,000, you can get this study done once every 10 years. That's $100 a year. You pay more than that in your cable television and your internet per month. Like we're spending money. We spend $60,000 on a new car, but like you're not willing to spend $1,000 every 10 years or less on your health. Like that's, you know, so that's sort of how I put it to my patients because once we get some results back, then we have something to work with. Then we can really focus, and it really helps with behavioral changes as well. Like, hey, yeah, you're going to need to stop drinking 2 beers a night because this is the result. We see this is the start, and it really makes a difference for a lot of people. So that's just the lifestyle medicine perspective of it on my side, I think. And Dr. Acharte, tell us again, like, what are you doing differently? What did you identify as the problems, and what are you doing differently?
Sure. So being out in practice for like 6 to 7 years in the greater Philadelphia area, I feel like I got a good exposure to common pain complaints. I quote things from the CDC with how many, like what crazy number of work hours are lost because of just back pain, what crazy number of individuals will experience debilitating joint pain and back pain throughout their lifetime. And then going into the medical space, how we're currently treating it, which is currently it's an assortment of oral medications, injections, epidurals, all these words that a lot of people probably have heard of in the past. But I think what's constantly not spoken about enough is exercise and stretching, like the things that one can do during their day-to-day life to prevent these issues, from getting worse, or the way I put it to people, preventing flare-ups. I think that one of the wonderful things that my core training in PM&R back at Penn really scored on, or really like tried to underscore, was getting people out and moving. Again, going back to like just healthy living, whether it be diet, exercise, what have you. I try to tell people our bodies are going to age, and there's some things that we can do for it and other things we can't. So there's an element of acceptance. And for that component of accepting, it's like kind of making the best of what you got left. And to optimize for that, we need people out there walking, exercising to whatever ability they can, obviously in a healthy manner. And then once I've created this picture for them, it comes down to a conversation. At least this is how I practice. I ask them, what is it that you want out of this treatment? Do you want a cure? Because if that's the case, then probably not going to happen. Again, depending on whom I'm seeing. Is it management, long-term management? What is it that you want? Do you want to spend a weekend with your kids? Do you want to be able to do something once a month with other aspects of your family? Is there some hobby that you really want to like reclaim? And we will have these goals of care, and we'll aim towards that. Like one thing that I constantly tell people is, I'm not here to cure you of pain. I'm here to give you a better quality of life. And I don't know to what extent I'll be able to do that, but wherever you are now, I can get you better. And we'll modify those things as needed. No two people are the same. People's goals are differently. And again, going back to my core PM&R training, it's interesting because it allows me to have different kinds of conversations based on what people want. If you have an individual that has end-stage cancer, for example, the goals really kind of very quickly go towards palliative care. It's not towards outright curing or anything. It's just like improving their quality of life. I have a decent number of patients who are very athletic. They literally, within the last week, I saw someone who is an ultra marathoner. These people are amazing people, right? But you're not going to treat them the same way you're going to treat an 80-year-old with arthritis in the back. Like their goal is to achieve a certain level of function, and my goal there, my conversation is really going to steer more towards sports medicine. Like, how do I keep this individual going at this rate, but making sure they understand that it's not going to be the same thing as like trying to preserve whatever cartilage they have left in their knees. It's going to be trying to preserve their function. And then for the vast majority of people, the general aging population, I would say it's going to be this other third group, which is having them understand the nature of their pathology, whether it be arthritis or pinching of the nerves, and having them understand what they can do to decrease what I call those flare-ups. At that point, I really call myself more of a firefighter. I'm like, these pain episodes that you have, fire is flaring up. Ultimately, chances are it's going to happen throughout your life, but I want to work with you to mitigate any of the risk factors to decrease those rates, and then what I can do to put out the fires when they do happen. Sorry, I know I spoke a lot.
And
No, that
I
makes,
want to add,
yeah.
oh, go ahead. Sorry, Daniel.
No, that makes sense. Go ahead. Mhm.
I want to add something. This is your question earlier about what's unique about Wisteria. That's kind of, Christian talked about it. We kind of play off each other. Christian sends patients to me for x-rays to diagnose, and then Christian's able to go ahead and treat based on that x-ray. We're obviously two separate clinics, so we're not connected, but patients can walk in, see Christian for back pain, and Christian can figure out, hey, is this sciatica, is this arthritis, or what's going on? And then they can get imaging the same day. Christian can find out, and the next day you're able to kind of treat. So it's very efficient, as well as we're both focused on healthy patients, like patients who work out, patients who have a very kind of holistic approach to life and eat well, and spiritual. And I think those patients obviously come to Christian to enhance their life, as well as we have DEXA scans so we can monitor their body composition, make sure they're doing the right things, as well as obviously calcium scores and coronary CTAs. But it's definitely pushing towards a full body, complete approach to health. Sorry,
Actually,
Dana. Go ahead.
If I could add one more thing, and Eric really alluded to this beautifully. And the way I tie this together, like this interaction that this thing that Eric and I created, is kind of akin to what we underwent in training during residency. We all trained at a hospital. We all had the ability to, and this will speak a lot to the medical professionals listening, but hopefully paint a picture for any potential patients that are listening. When we're in the hospital, we have the ability to literally just walk down the hallway and talk to our colleagues in a completely other department. One of the a curbside consult, if you will. And I know personally firsthand, a lot of times when I was training, I would walk down to radiology and ask them like, yo, can you pull this up and review this with me? I looked at this scan. I would like to see what your opinion is on this new one. And when we're out in I'm going to call it the real world, an outpatient, and working in our outpatient clinics, we are disconnected from one another. We don't have that ability to it's not as easy to literally pick up the phone and say, hey, can you help me out with this? In Wisteria, that is not the case. I can't tell you how many times already in our very short existence, I picked up the phone and asked Eric, can you look at this for me? Like, Eric, do you see this before and after? This is what this is what the patient's presenting with. What do you see? I know what I see. Tell me in your experience, what it is. And we've actually come up with a few added differentials to our diagnoses, like that is to say, adding some depth to our understanding of patient's pain, but also Eric has, in a lot of ways, contributed a lot to structuring my treatment plan for these people. And that's something that I didn't have in my prior place of work, but I did have in the hospital.
Yeah, I think that's beautifully said, because it's nice to get another specialty's perspective on, hey, I have this patient, these are the symptoms. Anything else that you might consider? Anything else that you think that I'm missing? Anything else that, any other treatment modalities that you think would be useful here? 100%. So maybe we can give a real life example of something that I'm seeing a lot in the community. I call it mouse syndrome. And so, so I'm going to explain. It's not like a mouse running across. So I feel like I have a lot of patients coming in with issues with like a flattened cervical spine, probably because they're working like this on the computer and they're using the mouse, and they're having like, when you get MRIs, there's possibly some mild narrowing of the canal. And then there's also, they're having like this, it's a standard pain. It's like pain in the rhomboid area. So like right back in here, and it tends to shoot down the arm into, a couple of the fingers, usually on the ulnar nerve side or so, but not always. So what would that person experience when they come to you guys, right? Like what would the couple visits and things look like in terms of what you have to offer them, what you might, suggest, et cetera? Because I think people understand imaging pretty well. but I don't know that they fully understand physical medicine and rehabilitation, because a lot of times we think of physical medicine and rehabilitation in the context of like of stroke rehabilitation, or like more of an
FUTs.
inpatient-ish or residential-ish setting. Yeah.
Sure. I'll start. So it really would depend on whether they come in through just getting a direct consult to the imaging side to get a picture, or they come to me first. So I'll speak as if it were coming to me. I would start off by getting a history, getting a list of symptoms and trying to put this piece together, kind of like just basic doctor work. And it would eventually lead to diagnostics. What they can get at Wisteria immediately is before they leave, after I speak to them, after I explain to the best of my abilities what it is that is likely causing their issues. And if it's more than one thing, I'll review the list of the most likely causes. They will be, escorted out into our adjacent imaging suite, where they have they can get a real-time X-ray, diagnostic X-ray, which Dr. Addo will read it within 24 hours. Or if I deem it necessary, we can do a CT scan, again, in-house. We have an in-house ultrasound, like all these imaging modalities that we can get immediately, so as to expedite the diagnostic workup. So that would be the initial care. Like if there is something that I can immediately do right then and there, like a quick trigger point, yay, musculoskeletal issue, and I explain to them how to relieve that stuff. But if it's something
that would be
more
like
involved,
that's a trigger. So just to clarify,
exactly.
Trigger point injection is you're injecting. You want to clarify what that is?
Sure. It's an injection that helps. What I describe kind of helps relax and numb up an area. The injection itself is designed purely to be therapeutic into the muscle tissue, into soft tissue. It's never designed to be deeper than that. It's not designed to be a nerve block. It's not designed to be any kind of joint injection. So it's very tailored to treat one specific kind of pain. And I describe it in the clinic as a Band-Aid. I'm like, it's a darn good Band-Aid, but it doesn't cure anything, because I'm like, what I tell people is like, if this helps you, then you really going back to that thing that I said, it really underscores exercise and stretching. You can do something in your day-to-day life to prevent this from happening. But if that is not where their pain is coming from, then at Wisteria, we're well suited to do any of those diagnostic nerve blocks or steroid injections, whether it be in the joints or other parts of the body or the spinal or along the spinal column. And I would work with people to see, okay, what has helped you, what hasn't, and in the process, explain to them what their options are. One of our core columns in education, Eric and I were going through medical school, at least that was drilled into me, was this notion of autonomy. And I think this resonates with every American. It's like things should be explained to the individual, and they should be allowed to make an educated decision on their own well-being. And I do try to do that to the best of my abilities, as fast as possible, with Eric's help in imaging. And it's not uncommon for me to just pick up the phone and call Eric, like, we had this, what are your thoughts? And he will point me in the right direction sooner rather than later.
And so with the interventional, I think that's helpful. And with the interventional aspect of it, there's other modalities that you can offer in your office.
Mm-hmm.
And you were saying like nerve blocks are some of them.
Yes.
And are you using ultrasound for those things? Like, can you explain a little bit more about the other modalities that you use that are interventional per se?
Sure. So regarding image-guided injections, the two things that I primarily would use within Wisteria's capabilities right now are ultrasound guided, and we have a great ultrasound machine. Again, diagnostic level ultrasound, and a fluoroscopy imaging. So basically, live X-rays that will point me in the right direction, so I can get right into like the safe spot, sweet spot, if you will, to get rid of the pain. So those are the two modalities I tend to use for imaging. Because we have a CT in-house and because Eric is an interventional radiologist, it is not outside of the scope to potentially even refer back to Eric and have him do some type of CT-guided injection. And we have spoken about that on a few patients. We have actually, and I think this is a responsible thing for physicians to say, just say no to things too. Eric, there was one time I asked him, like, what is your opinion on doing nerve block for a particular individual for who was having like facial pain, going in behind the ear, like or whatever, and doing a trigeminal, hitting up the ganglion.
Right.
And I think we both made a decision that given what was going on, it would be unsafe or too high risk a procedure.
Just following that point, I feel like just having that kind of multidisciplinary team in an outpatient setting, I'm sure, Dana, you see it a lot as a primary care doc. You want to refer to people that you can kind of talk with, you can kind of trust. And I think building that, it's tough for patients. If they're not in a hospital, it's tough for other physicians to consult other specialties very easily. So with Wisteria, that's kind of what we want to build, is kind of that multidisciplinary environment where Christian can come to me and ask me questions, and we have that. And then for your patients, if your patients have a question about radiology, you can call me, call Christian if it's about pain, and we create that kind of environment. And I think that's the future of healthcare, where it's not always in the hospital, where patients have to pay. Those self-pay numbers in the hospital are very high, like 3,000, 2,500 for different things. We can do this in an outpatient environment, and it's a little more focused on the patient, and you can see a doctor for longer, and just kind of the practice you're building. And that's kind of what we want to kind of supplement, from the radiology and pain side, is what you do with your patients. You're able to focus on them, be very patient-centered, and then we're doing that for radiology, and Christian's doing that for pain, where patients just have that very tailored experience. So.
Yeah, I think that's really important. I actually just sort of I posted on our local physician moms group and started a Google form, and so we have a cell phone exchange going in whoever wanted to participate in it, which is awesome because we understand everybody's busy. Obviously, we're not giving out people's cell phone numbers. This is an internal thing, but like it's really helpful. I have a cardiologist right now that I'm trying to get a hold of that one of my patients went to, and it's something important, and I'm like having to go through the front desk for this stuff. And nothing's happening in a timely fashion. I have to wait until he's ready at the end of the day to call me back. Like, no, I just want to shoot you a text message real fast, just to give you a heads up or tell you what I'm concerned about after talking to the patient. And so I think like that open communication is so, so extremely important. And then the other aspect of it which was what you touched on, was the corruption within healthcare. And this would be an entire other 10 episodes. But that's also one thing that we're trying to address with our sister company, Verity Advisory, is helping individuals and businesses get out of that corruption within healthcare, right? Because anything that you run through health insurance is automatically likely going to be 6 to 10 times higher cost. Anything that goes through like Blue Cross, United, Cigna, Aetna is just, so it's really helpful to have businesses to work with that understand this, and they're willing to give like what they consider to be their fair market, what your prices are, which has been great working with you guys because it's nice. And there's more and more patients that are opting out of insurance. Like I don't have insurance. I have a health sharing company that I use for myself. I'm relatively healthy. They covered everything that I needed 100% with my recent hysterectomy. There was no question in mind. It was a very clear-cut situation. And the rest of the stuff I pay for out of pocket, or what's considered self-pay. And more so, like we're trying to help small and medium-sized business to understand how they can actually create a self-pay environment within the business as well that provides better care with a concierge doctor at the core of everything for their employees, and then just affordable self-pay pricing via like sort of a loose network, right? If we know that these people are willing to be transparent with their costs. Cost transparency is so important. So we're talking all about ethical practices, right? It's ethical to have time with your patients. It's ethical to have relate to people as humans, to validate what they're going through, to not gaslight them. Like all of these, it's like, let's get back to ethical practices, right?
I think you're making a great point, Dana. And I think I mean, what you're saying is, from my experience, from what I've read in reports made by very big consultants like Deloitte and McKinsey, that America's healthcare system is transitioning away from like major hospital based to like more outpatient based. And the system that you were just describing, like something that'll make it easier for primary care doctors or outpatient specialists to thrive within this new environment, whatever the heck it's going to end up looking like. I don't think anyone knows, but I think anything that makes it easier and allows a provider to grow or to have more time with their patients, like you described, is going to be a good one. And I'm actually kind of excited to see where it's going to end up.
Yeah,
all I can say is work hard and do the best we can. Sorry, go ahead.
Yeah. And we need to put I always say patients or consumers, right? Because patient sort of has a sick connotation to it. I got this terminology difference from my interview last week with the COO with Chris Turner from HealthBook Plus. But like, we need to put the consumer back at the center, right? It's crazy that people can't, they're like, oh, I don't know where my medical records are. I can't get that information from you. I don't, So and it's also crazy that somebody comes into an office and feels like something is either pushed upon them or like it wasn't their decision to be made about their own health. And it, in my mind, just from the basic philosophy of humanism, it's crazy that people actually are still experiencing that. So just putting, the power back in the hands of the consumer, and as physicians, we are advocates for them. Like, we are saying, these are what we believe are your options. And, if you don't like what we have to say, that's fine. Like, go get another opinion. But we're not forcing anything upon you. I think that type of relating to somebody with just that basic level of respect as a human really changes the relationship, and helps to develop and foster a relationship of trust. Because without trust, we have nothing, right?
Yeah. Underpins everything.
Yeah. And that brings us back to your initial comment on how, it's really important to trust somebody that you go into business with.
Absolutely true.
Yeah. So I think we covered everything. I'm just aware of the time because I know we only had scheduled till 11 o'clock. Is there anything that you guys want to close with in terms of like anything that we didn't mention, anything that you just want people to know?
Eric?
I would say, going back to your point of trust, I think that's the main thing. With obviously, if someone's trying to build a imaging center or pain clinic, obviously trust your business partner. If it's any interaction with patients and doctors, trust is important. Just looking at the numbers, I was actually looking at the self-pay numbers yesterday for the hospital. They charge $3,000 for a lot of these scans. And I look at it and I laugh because I see, if a patient sees $3,000 for a coronary CTA, how can you have trust for that system when they're asking you to kind of spend that much and invest that much into a system? There's a lot of disconnects in our institutions on caring about patients and their situations. And I think Christian and I are creating that environment, and Dana, you're creating the same environment where you can have patients like understand where they are in life. No one wants to spend $3,000 for a coronary CTA or studies because they have other things to do in life. And so I think that trust at a very basic level is what we're trying to bring to Wisteria.
Yeah, it's also just that's not the cost of it. It's just it's a middleman inflated cost. So let's get back to basics for a lot of people. If people want to use their insurance, they can. It sounds like you guys are getting credentialed, and finishing all the credentialing, with insurance companies. But I think it's also important for people to really understand their costs. And I'm very transparent. I put my self-pay, what my costs are for my medical center on my website. And I think it's so important that like everybody else just start to do that. And like, these are our costs. This is it,
Exactly.
Just call us and ask us if you need a discount. I don't know, maybe we can give you one, but call us. Like, this is just the basic of humanism again. So
The open market argument. I like it.
What's that?
Open market argument. I like
exactly. 100%, And I don't know who knows if it's like evil, and there is a lot of, like fiduciary responsibility, and that's a whole other podcast in itself. Like, I think in the future, a lot of possible brokers and other people are going to start to find that they're getting sued for breach of fiduciary responsibility, because they're basically like selling these insurance plans that have really high costs involved for everything about the insurance plan, when we know that the actual cost is 7 to 10 times less than what it is, right? So I think there's more cases that are starting to come up within the legal system of like breach of fiduciary responsibility. So I think that's, transparency is very important in that sense. So anyway, it was awesome to talk to you guys. Let me
Thank
just
you
put
so
this
much.
up at the bottom real fast. Let's see, add banner. Correct me if I'm wrong. Is this the correct website for you guys? Wisteria.health?
Yes.
Correct.
Yeah. Okay. So this is your website, and I will put, when I repost this, I'll put all the information in the show notes and everything. It can be on YouTube, and I'll repost on Instagram and everything. But also sort of a link to your social media as well, if that's all right with you.
Oh,
Yep.
absolutely. Thank you
Yeah.
so much.
Thank you. Thank you,
Yeah.
Dana, again. Yep.
It was
And
so great to talk to you
Yeah,
guys.
great
I'm so
conversation.
looking forward
Likewise.
to continued collaboration.
And thank you for what you're doing. I do think it's super important to like find other avenues to support our patients outside of the system, especially if it provides better care and easier access.
100%. Yeah. Thank you. Right back at you.
Thank you again, Dana.
Very grateful.
Great work, Dana.
Okay.